Historically, primary care has little to do with clinical trials for cancer treatment. However, patients are learning about them in all sorts of different ways. And with more clinical trials research involving primary care directly, I wanted to investigate how trials work and what support patients may need from their GP and primary care teams. Dr. Natalie Cook, consultant at the Christie NHS Foundation Trust and the clinical lead for the Manchester Experimental Cancer Medicine Centre, sat down with me to explain more.
So clinical trials are a form of health services research. So if you look at clinical trials specifically, it's where we look at interventions. So these can be things like new diagnostic tests. These can be new drugs, which is what I work with. And essentially patients then consent to go onto a clinical trial to look at how these interventions can potentially help them. Quite a lot of clinical trials happen in secondary care, so in hospitals. But we do find that we have an increasing amount of research and clinical trials in the community setting, so within primary care. And I think that's really important because as we change to treating lots of cancers to try and preventing lots of cancers, we need more and more research within that primary care setting.
So primary care are actually now getting involved with clinical trials themselves?
I mean, certainly for screening and kind of early detection of cancer, we don't just need patients that have been diagnosed with cancer. We need that population that perhaps is at high risk, or even just the general population, to look at how these new screening tools can work. We need anyone to try and get involved with clinical research and clinical trials. And again, even if it doesn't benefit them, it can benefit people in the future.
Can you tell us about the different phases of a clinical trial?
When you're looking at new interventions, so whether that's drugs, radiotherapy, or sometimes surgery, you then look at how the phases of trials work. A phase 1 trial is where you are looking at the intervention in the first setting. So you're potentially taking a drug that has never been used in patients before and looking to see how safe that drug is, how tolerable it is, how it affects the body, and actually also what effects that drug has on the body. So is it doing the thing we want it to do? If the drug then is safe and tolerable and we think it's shown enough evidence that it can go to the next phase of trial, it would go on to a phase 2 study. And a phase 2 study is where you take that dose of drug and you look to see how effective it is in a certain population. So in a phase 1 trial, you might take lots of different patients with lots of different types of cancer. In a phase 2 trial, you might say, I just want to try breast cancer and see if that's where it's most effective. And so we go into a phase 2 trial. And after that stage, if we think it's effective enough, it would then go into a phase 3 trial where you take the drug or intervention and see how it is compared to kind of the gold standard. So what you already use in that cancer type. So for example, if chemotherapy is a standard of care and you've got a new targeted treatment, you might want to compare the two to see which one's the best treatment for the patients. And sometimes we do stage 4 trials so that we can still capture safety data from drugs.
Have trials changed over the years?
Interestingly, because we have now things like immunotherapy approved for cancer treatments, we have much more targeted treatments, and we're looking at trying to give patients more personalised therapies. What that means is we've had to kind of look at the way we do clinical trials, because it was a little bit clunky because we'd go from phase 1, stop, phase 2, stop, phase 3, stop. But we now know that we can do more seamless trial design. So for example, if you're looking for a patient with a specific genetic change in their cancer, and actually that's only going to be small numbers of patients, you can design a trial specifically for them, and it can be looking at the safety and tolerability, and then looking at the efficacy in a specific patient population, all rolled into one. So we don't have to stop and start. It's a much quicker way of getting drugs to the clinic as standard of care, because we're getting better at developing these drugs as well. And hopefully that means the treatments will reach the clinic faster.
I have patients coming to me in primary care saying that they have been offered a potential clinical trial. What is the best advice and guidance primary care can give, and where also can they find this information?
If a patient's been offered a clinical trial, they would have normally been given quite a lot of written information on the clinical trial. Now, that can be quite overwhelming because, I mean, for phase 1 trials like I do, some of these patient information sheets can be 30 plus pages. And so we ask them to read that and take their time to consider it. We also have our clinical nurse specialists in the hospital that can answer any questions. They have their normal oncologists that can answer any questions. And it's important that they have those questions addressed before they sign any consents to go on the trial. And then from a GP's point of view, my hope is when I always speak to patients, I'm like, if you're going to see a GP, take the paperwork with you so the GP can understand what you are like thinking about signing up for. But actually those information sheets will have what the potential benefits of the trial are, what the risks are, what the side effects are, and hopefully let them understand a little bit more about what that trial is.
Patients sometimes come to us and say, we've heard about this particular clinical trial, how do we get involved? So how do patients enter and get involved with clinical trials?
Yeah, so we get the vast majority of our referrals from patients' primary oncologists. And the reason for that is that we need quite a lot of information about the patients to see if they're eligible for the trials, because trials do have kind of strict eligibility criteria. So if a patient came to one of their GPs to say, can you put me forward for a clinical trial? I mean, we still advise them to go through their normal oncologist, who can then send all the information we need so we can assess eligibilities.
Learning about the phases, the protocols and the processes gave me a greater awareness of clinical trials. But I wanted to know about the patients on a trial and those that might come to see me. If a patient is on a trial, what can they expect and almost what happens next?
It can be a relatively longer procedure than a sort of a standard of care treatment. So normally we'll identify a patient through our new patient clinic as being suitable for a trial. So there's that initial assessment there, and to check that that patient's also interested in trials as well. We get referrals from the patient's oncology team, so they'll refer to us that way, and that's the initial way that they'll come through to us. If from that new patient clinic, patient is well, they often go onto one of our waiting lists, or occasionally we might have a trial sort of available for them to go forward with. The next steps are the consent process. So a patient would have an informed consent. We would give them information about the trial to read through beforehand, a chance to come in and ask any questions. There's then a screening process that patients have to go through. That normally takes a couple of weeks to do before we can actually go ahead with sort of delivering that first treatment.
So if patients partway through the trial are starting to experience side effects, they come and see the GP, what happens next? Who should they contact, and what's the best course of action?
So normally the sort of key person is the patient's research nurse. And when a patient starts on trial, we will give them all the information of people to contact. So normally they would have that information there, but if they have come into a GP consultation, experienced something, get in touch with our team. So again, we have details for the research nurse that the patient should have. We give them a hotline card as well, which normally has the trial information on, so they could call through to the hotline as well and just say, if you were particularly concerned about a patient, maybe you were worried they might need to be admitted, that's normally a good route as well, or whether there's a certain treatment that you want to try, and we just check that that's okay with a trial protocol. They can be quite restrictive in terms of supportive medications that might ordinarily work well to control, say, sickness or nausea, but may be prohibited by the trial. So we always like to check that it's not a medication that's going to interfere with that novel drug.
After the trial has completed, how long are the patients under your services for?
Some trials might end sort of at that sort of end of treatment visits. Most often there's normally a sort of 30 to 60 day where we'd sort of actively follow up that patient. That might go on long with certain trials where we sort of contact them every 3 months just to check how they're doing, that they haven't had any new sort of side effects from the drug whilst it's still in development. For my service as a nurse specialist, I kind of say that kind of carries on as long as a patient needs to contact. It keeps that sort of communication with the team open. And just allows them a point of contact as well. So if they are waiting to see their oncologist and they don't quite know where to go, they can still sort of ask for advice from me.
As I started to get an understanding of trials from a professional perspective, I wanted to recognise the real impact a trial could have on a patient. I spoke to Elaine. Elaine received standard treatment following a diagnosis of triple-negative breast cancer in 2022, and more recently has been actively involved in clinical trials. Once you were diagnosed and you went through the standard treatment that we talked about, the surgery, chemoradiotherapy, what happened next and how did you get involved in clinical trials?
I was actually on a Facebook group that is for triple negative breast cancer patients who obviously just talk about symptoms, that kind of thing. And a few people had been talking about a trial where it was looking at ctDNA in your bloodstream, and it was something that really interested me because, of course, with triple negative is something that's got a high reoccurrence rate. I actively contacted the trials department to see if I could access this trial, which I was allowed to do, thankfully.
So this trial that you started on, it was to pick up any cancer cells in your bloodstream, which would then lead to a recurrence. You were then started on preventative treatment because of the results of that?
Yes, so they did put me on immunotherapy, which kept it at bay for quite a while. Once that wasn't working and I did find the reoccurrence, I then was put on another trial.
And how is it being on a trial? Talk me through the different stages.
It's something that I actively encourage people to do. There's so much thought process that it's actually the last resort, but that certainly isn't the case for myself. I was given either a start on the trial or I could go on standard care of treatment. For me, it felt like actually I was getting given an additional treatment that actually has worked wonders for me.
What's the process of enrolling in a clinical trial?
You get given all the information. You're able to drop out at any time. If you ever feel uncomfortable or you ever think, actually, this is not for me, I'm actually not going to do this, you can drop out at any time. Nobody puts any pressure on you. You're getting given all the information that you need. Any side effect imaginable to tell you about. They always make you feel like you can ask them anything. You know, as a cancer patient, you want to be able to make an informed choice yourself.
And I remember you mentioning when we were having a conversation earlier that the workup for the trial from a physical point of view, you were checked from head to toe.
It's absolutely incredible because, you know, my eyes were checked, my heart was checked. I get regular CT scans every 6 weeks. It does make you feel reassured. Your health is actually the most important thing to them.
Me being a GP, I'm interested to know what we could potentially, let's talk about the royal we, I'm talking about my primary care colleagues and I. What would you like us to do? I'll put it back to that way. What do you think we could offer?
I think what is really missing is mental health help, you know, and
support.
Yeah, anybody going through a cancer diagnosis, your mental health is going to be affected. Now, I'm not saying that my GP has never said to me, you can contact us about mental health, but my fear factor with that was they would give me drugs.
And there are other things that we can do that it doesn't involve just giving antidepressants. We could refer you to, there's charities and support groups and things that we know locally.
They could actually say, well, you know, this is something that we can offer if needed.
It's important to understand how clinical trials work and how we can get involved. But more than that, it's important to identify when patients might need additional advice from their GP. Our relationships with patients put us in a privileged position to support them through a trial or signpost them to local services. We shouldn't assume patients already know what's available. And with clinical trials growing in the primary care setting, we may find that more of our patients are on a trial, and we need to recognise our role within this.